Yes, ma'am. Yes.
I know everybody's bodies are different and everything. What is the recovery time like?
Okay, that's great. So I'll answer that for all. Specifically, you're asking about the sleeve, but the recovery time is about the same for all 3 surgeries. So when you look at the adjustable gastric band, that can be done sometimes as an outpatient, okay? But most insurances want you to stay overnight, and that's fine. I'd prefer that as well. And then you can expect to go back to work, I don't know, in about 10 days or 12 days, something like that. The other 2 surgeries, you're usually in the hospital for about 2 days. So as I mentioned before, I usually operate on Mondays and Wednesdays. Sometimes I do it on Tuesdays, but usually home by a Wednesday or a Friday. And then I tell people to take about 2 weeks off of work, okay? If you do heavy lifting and things like that at your job, then you're gonna wanna do light duty when you go back to work for the next 2 weeks after that, so full 4 weeks. But in general, most people can get back to 2 weeks, and if you're at a computer or call center and stuff like that, that's usually not a problem.
On the
Yes, sir.
sleeve, do you hand stitch that staple?
I don't. It's a great question. So on the sleeve, do I hand stitch? I don't. I selectively oversew areas. So when those staple lines intersect or go across each other, if I have any concern, I do. I sew there. What I didn't mention is with all 3, or with the sleeve gastrectomy and the gastric bypass, we do check for leaks in the operating room. So I use an endoscope. I go down into the mouth, and we fill up the belly with some fluid around that area where the connections are or the staple line is, and then we use the endoscope and insufflate air. And if there's no bubbling, there's no leak. So we check then, and then the next morning on those 2 surgeries, we send you to the X-ray department, and you drink some contrast, and we check for a leak as well that way. So now there's two tests to prove you don't have a leak. But to your question, there are people who do oversew it. Sometimes if you oversew the whole thing, you might narrow it too much, and then it's really difficult. So, and that's why we kind of just selectively do it. Yes, sir? What if you have a hiatal hernia? So if you have a hiatal hernia, we're going to fix it at the time of surgery. It's pure and simple. Doesn't matter what operation, we're going to fix it. Huh? Well, so we can't really get rid of it. So the hiatal hernia is a hernia or an opening in the diaphragm, and normally it looks like a teardrop about this big. And in people who have a hiatal hernia, it's often bigger. So what we have to do is bring this bottom part tighter. So we tighten it up. Now, the reason that people have good success after this operation with a hiatal hernia repair is that as they lose weight, there's not that pressure that's in the abdomen pushing and causing the hernia to stay open. So that's why there's better success. But if we don't fix it, you'll probably have some level of reflux, and we don't want to do that. Yes, ma'am?
I understand the soda, the no soda.
Yeah.
Why is the milkshake?
Like milkshake, just the high calories.
Oh, okay.
Yeah. Now and I mean, when I say milkshake up there, I'm talking about your McDonald's kind of milkshake. I'm not talking about protein shakes and things like that are going to be potentially good supplements for you in the early stages after surgery.
Okay.
Yes, sir?
What are the A1C considerations?
So what are the hemoglobin A1C considerations for that's the marker of type 2 diabetes? I don't know that that's a great question. I don't know that I actually have a requirement. I've taken care of patients whose hemoglobin A1Cs are 13. I don't like to see it that high. I definitely want to see if there's some level of control, but I also know that when we do that person, I'm going to tell them they need to bypass, right? But, 9s, 10s, I mean, we see people's hemoglobin A1C start to drop very rapidly. And I'm not sure if it's in this one. Chris, who's on the right, had really elevated hemoglobin A1Cs. He's on the packet. And after surgery, immediately they started dropping. Within a month, his hemoglobin A1C was almost normal. So it's pretty good. Yes, ma'am.
Have you ever done a patient with von Willebrand?
Have I ever had a patient with von Willebrand's disease? I do not believe I have. It's not with weight loss surgery, but we have taken care of patients in other surgeries I've done.
So you don't see that as a problem?
I don't think so. I would definitely consult with the hematologist and see what we need to do to be sure that we protected you, for you. Yeah. Wow, come on. This is just audio, guys. You're not on camera. It's okay.
And I've had other surgeries, so I haven't had
You've been
an
okay.
issue.
Good.
And for the payment, or for
Mhm.
the cost,
Mhm.
all the, what happens before then, is that included in the cost, or is it?
So the question is costs. And I guess from insurance perspective, everything is, we use your insurance for everything we can, of course. And most everything is covered. It's rarely not covered by insurance. So it's just a matter of your deductibles and out-of-pocket expenses that you have. But yeah.
So you're saying those things could be covered even if the surgery itself is not covered?
But yeah, potentially, that's right. Yeah, so that's definitely one thing. So the question is, can the preoperative workup be covered even if you don't have a benefit for surgery? Like you have insurance, but you have an exclusion on the policy. Yeah, we usually use your primary care doctor in those instances to get things ordered and stuff, because if they feel it's necessary, then it's good, you know, and it's appropriate. I mean, a lot of the stuff we're doing that maybe things I didn't even mention, you know, if you're a woman, we get a mammogram, you know, if you're over 50, we want colonoscopies. I mean, we want things that are health maintenance things to ensure that you're as healthy as you can possibly be before we do surgery on you. And so that's really important. Mm-hmm. Yes, ma'am.
You were talking about the absorption,
Mhm.
like for like the medicine absorption.
Okay.
Sleeve versus the gastric.
Mm-hmm.
In the future, you know, if you have to take, you know, one of those medications, are you still going to have that problem?
So the question is, between the gastric bypass and the sleeve, in terms of absorption of medications down the road, is there a problem? So what I can tell you is, you know, immediately the gastric bypass, the absorption may be different. In fact, so with the bypass, the absorption can be better in certain instances. For example, alcohol, which I don't recommend you go out and start drinking after a gastric bypass. But alcohol is absorbed very quickly, that small intestine. So the small intestine may absorb actually better or worse, depending on what it is. So in that instance, you know, a glass of wine, a third of a glass is probably equivalent to a full glass of wine in a bypass. So that could be a problem. Medications like Coumadin or things like that, or transplant. Somebody has a transplant or has an immunosuppressive medication and the absorption. You know, again, we're not really sure. What we do know is that intestine that's bypassed tends to, over time, get better at absorbing because it increases its surface area. But it's hard to know exactly for sure. The sleeve, we just don't see so many problems. But that having been said, you know, we definitely have patients who've had a gastric bypass and then years down the road they develop, you know, maybe they got epilepsy or they had, you know, a blood clot and they had to be on medication. That doesn't prohibit them from doing that. We just have to be really careful about what medication they're on and do they need to be on something else to protect them. So if they have to go on because they have severe arthritis, you know, years later, and they have to be on a steroid or ibuprofen, then they need to be on an acid-reducing medication to help make sure they don't develop an ulcer or something.
Okay.
So, but if we know up front, I try to, you know, veer towards the other. But if we don't know, it doesn't mean later it won't be, it would be bad.
Okay.
Yes, ma'am.
What about a patient with a history of multiple abdominal hernias and adhesions that are left from that?
Yeah. So the question is, someone who has had previous abdominal surgeries, multiple abdominal surgeries, maybe hernias as well, and scar tissue. Yeah, that adds complexity to it. I don't think it's an immediate exclusion. I think you just have to ask what you've had done, why did you develop hernias? You know, maybe you had a surgery, had an infection that led to the hernia, and that's different than someone whose abdominal wall is just really weak and is going to just be prone to hernias. So we just kind of have to talk about that individually. But that does not mean an immediate exclusion. Okay. Really? That's it? Really?
I have one.
Yes, sir.
For a young woman on either the sleeve or the bypass,
Mhm.
say in the future, pregnancy, the nutritional
Great.
aspect of it.
It's a great question. It's a great question. So if someone wants to get pregnant after weight loss surgery, sleeve versus bypass and nutrition. So the real thing to think about, after any of the surgeries, I wouldn't recommend anybody get pregnant within 12 to 18 months of surgery because your body just does not have the capability to share. Becomes very selfish for that first year, which is fine, it should, but it won't share the nutrients that your body needs to share to have another growing person. So, but after that, usually not a problem. I would just say that that individual is someone who an OB might consider higher risk in the sense that they should really be followed by both the bariatric surgeon and the OB just to ensure that you're getting all the right nutrients that you need and the baby needs in order. But yeah, pregnancy after is not a problem in any of them.
And in some cases, with the pregnancy,
Mhm.
sometimes if you're trying to get pregnant and you
Mhm.
have a weight issue, when you lose the weight, you're more likely to have a baby.
That's a great point. Yeah, fertility. In fact, one of the indications that we don't have listed up there is for fertility. Definitely, patients who after surgery have had weight loss have an improvement in fertility. Not always, but many times they do. And that's one of the things that can be the surprise that people don't realize that 6 months later they're pregnant and they're like, how did that happen? And honestly, because going along all the time, they never had that issue. So you have to be really aware of that during those early phases after surgery. But yeah, thank you. Okay. Well, thank you very much. I appreciate all your time.